So one of the areas of controversy is with regard to induction chemotherapy followed by chemoradiotherapy in stage 3 disease. I mentioned before that systemic micrometastatic disease is a huge problem in these patients, and one has to give adequate, effective chemotherapy in this setting. We typically give chemotherapy with radiation, but radiotherapy strategies typically last 6 to 7 weeks, and therefore that would really account for essentially 2 cycles of chemotherapy. Now, in stage 2 or 3, when we are giving adjuvant therapy, or in the metastatic stage 4 setting, our current standard is to give 4 cycles of chemotherapy in that setting, maybe sometimes 6 in the stage 4 setting. So I've always wondered, why would we just give 2 cycles concurrent with chemoradiotherapy in stage 3 setting? However, I will tell you that all the level 1 evidence does not routinely support the use of more chemotherapy other than during the radiotherapy. Obviously, it could be given before as so-called induction, or it could be given after chemoradiation, so-called consolidation therapy. Many investigators have pursued giving 2 cycles prior to initiation of chemoradiation. That's a strategy that I like personally and frequently do in my practice. I don't have level 1 evidence to suggest that it's a strategy that has in clinical trials, which in my opinion have been limited and relatively small in number, so relatively underpowered in this setting. But the advantages of induction therapy is often patients are symptomatic. The response rates tend to be in the 40 to 60%, depending upon which study you look at. A response makes the patient feel better because their symptoms may get better. But the other thing it does is that it may allow a smaller field of radiation if you believe that it's okay to treat the volume of cancer that is present after chemotherapy, which is what we do at our particular center. So it may allow a smaller field of radiation by using induction therapy that may then reduce the toxicities you may see during chemoradiation. Again, this strategy has not been proven at the phase 3 level 1 evidence. However, it's very commonly used, and I will also note that it's very common for practicing oncologists to recommend 2 cycles of consolidation chemotherapy if the initial treatment is concurrent chemoradiotherapy. So rather than give chemotherapy before, it's given afterwards. Again, not a proven strategy at the phase 3 level 1 evidence point of view. However, many of our major clinical trials done in cooperative groups allow 2 cycles as consolidation therapy, which is typically what is commonly done in practice. My personal bias is that you should think about giving 4 cycles in this particular setting. I think 2 cycles are inadequate to control micrometastatic disease, particularly if during radiation, the chemotherapy strategy that's pursued is low-dose weekly approaches, which may not be the optimal way to control systemic disease.